Take a look at this waveform before I name it. Notice how the upstroke, the moment exhalation begins, doesn't shoot straight up the way it does in a normal breath. Instead, it crawls upward in that long, slanted climb. That shape tells you the patient is trying to exhale through narrowed, collapsing airways. This is the classic obstructive pattern you see in asthma and COPD. The lungs can usually take air in because inspiration is an active process, but exhalation becomes a battle. Those swollen, constricted bronchioles act like tiny valves that partially close on every breath. So CO2 doesn't exit quickly, it escapes slowly and unevenly, and the waveform reflects that struggle from the very first moment of exhalation. What's happening physiologically is that the body is still making CO2 at a normal metabolic rate. The heart is still pumping it to the lungs, but the lungs can't get rid of it efficiently. That mismatch pushes the patient towards CO2 retention and the early stages of respiratory acidosis. Clinically, this waveform is your early warning sign. The patient is still moving air, just not well. You may hear wheezes, see prolonged expiratory effort, or notice that each breath looks like hard work. The good news is that the body still has room to compensate, and this is the moment where bronchodilators, oxygen, and reducing bronchospasm can make a big difference before things get worse. Now compare that to this waveform. Even before I tell you what it is, you can feel how much more distressed this pattern looks. The upstroke is painfully slow, almost dragging itself upward. The plateau isn't really a plateau anymore, it bulges and distorts, and the breath never seems to return cleanly to baseline before the next one starts. This shape tells you the obstruction is no longer just affecting exhalation, it's now affecting every phase of the breath. In severe asthma, COPD flare-ups, anaphylaxis, or attention pneumothorax, the airways can become so tight or compressed that both inspiration and expiration are limited. The patient is trapping air with every breath, building intrathoracic pressure, and losing the ability to clear CO2 altogether. Physiologically, the situation is spiraling. CO2 production continues because metabolism never stops, and the heart is still delivering blood to the lungs, but the lungs simply can't release what they're being handed. That leads to a steep drop in pH and a dangerous rise in intrathoracic pressure, which can start to compromise venous return and cardiac output. When you see this waveform, you're looking at a patient who is running out of gas, sometimes literally. They may be exhausted, altered, or even quiet because they're no longer able to move enough air to wheeze. In these moments, early recognition is everything. This is where bronchodilators, steroids, epinephrine, magnesium, decompression for a suspected pneumothorax, or ventilator adjustments to allow a long, passive exhalation can be life-saving. This waveform tells you the airway isn't just obstructed, it's overwhelmed, and the clock is ticking. Thanks for watching. If you found this helpful, go ahead and like the video and subscribe to the channel so you don't miss the next one. And if you want the full masterclass, along with tons of other high-yield medical education, visit academy.emergeprep.org. And I'll see you in the next lesson.